Bismillahirrahmanirrahim. Today we will discuss about the acute pancreatitis. Our objectives in the acute pancreatitis are to understand the anatomy and physiology of the pancreas, the clinical presentation, investigation of the pancreas, assessment and management of pancreatitis. First of all, we will see the surgical anatomy of the pancreas. The name pancreas is derived from the Greek pan for all and krias for flesh. So pancreas is all the flesh. The pancreas is situated in the retroperitoneum and it weighs around about 80 grams. Of this, 80 to 90% is composed of exocrine acinar tissue, which is organized into lobules. Then if it is divided into three parts: head and neck and body and tail. The head occupies 30% of the gland by mass, lies within the curve of the duodenum, overlying the body of the second lumbar vertebra and vena cava, while the neck, the aorta and the superior mesenteric vessels lie behind the neck of the gland, and the body constitutes about 70% of the pancreatic tissue. As for the blood supply of the pancreas is concerned, it is mainly from the celiac artery and the superior mesenteric artery. The celiac artery gives the common hepatic artery. The branch of the common hepatic artery, the gastroduodenal artery, gives branch the superior pancreaticoduodenal artery, which divides into anterior and posterior branches. Similarly, the superior mesenteric artery gives the inferior pancreaticoduodenal artery, which further divided into anterior and posterior pancreaticoduodenal artery. Here you can see again how the pancreas looks. As for the incidence of the acute pancreatitis is concerned, we can see that the acute pancreatitis accounts for 3% of all cases of abdominal pain. And the hospital admission rate for acute pancreatitis is 9.8 per year per 100,000 population in the UK, and worldwide it is 5 to 50 per 100,000, while the disease may occur at any age, peak in the young men and older women. Now, the etiology of the pancreatitis. As for the etiology of the pancreatitis is concerned, there are two major causes of acute pancreatitis. One is the biliary calculi and the other is alcohol abuse. In our society, the biliary calculi are accounts for 50 to 70% of the patient, while in the Western world, the alcoholic abuse constitute about the 50% or more. But here they are only about 25% of the cases. Then the other factors which are responsible for the acute pancreatitis, they are the post-ERCP, abdominal trauma following biliary upper gastrointestinal or cardiothoracic surgery, ampullary tumor, drugs like corticosteroids, thiazide and statins. Then hyperparathyroidism, hypercalcemia, pancreatic division, autoimmune pancreatitis, hereditary pancreatitis, viral infection like mumps and coxsackie, malnutrition, scorpion bite, and certain RPC cases. There is one acronym, you can remember it very easily for the etiology: I get smashed. So if we see, the I means idiopathic, G means gallstones, E means ethanol, alcohol, T for trauma. Similarly, S for scorpion bite, mumps, autoimmune disease, steroid, hyperlipidemia, E for ERCP, and D for mumps. So the mechanism of gallstone pancreatitis, actually pancreatitis is triggered by the passage of gallstones down the common bile duct. The obstruction of this passage may lead to reflux of bile or activated pancreatic enzymes into the pancreatic duct. Then a small gallstone and a wide cystic duct is most probably a higher risk for passing the stones, and that may cause the obstruction. You can see in these pictures and assess how it is. Alcohol. Some patients develop the symptoms of acute pancreatitis after even taking a single exposure to the alcohol, but most commonly it comes in after the patient take alcohol for at least 2 years and up to the 10 years. The mechanism for the acute alcoholic pancreatitis include the effects of diet, malnutrition, direct toxicity of alcohol, concomitant tobacco, smoking, hypersecretion, drug obstruction or reflux, and hyperlipidemia. The secretion will block. Theory for the alcohol. What is that? Actually, this is that the ethanol causes spasm of sphincter of Oddi, and this ethanol is a metabolic toxin to pancreatic acinar cells, where it can interfere with the enzyme synthesis and secretion. The initial effect of ethanol is a brief secretory increase followed by inhibition. This can lead to elevation of enzyme protein that can precipitate within the pancreatic duct, and then calcium precipitate within this protein matrix, causing multiple ductal obstructions, while continued secretion can cause pressure buildup, and this leads to pancreatitis in abscess. How does the pancreatitis present? The clinical presentation, the most common is the pain, which is very severe, constant, and refractory. That means it does not relieve with ordinary medication. It characteristically develops quickly, reaching maximum intensity within minutes rather than hours, persist for hours or even days. Pain is usually experienced first in the epigastrium, may be localized to either upper quadrant or felt diffusely throughout the abdomen when the pancreatitis develops. The addition to the back is only in about the 50% of the patients. Then the patient may have nausea, vomiting, retching, or hiccup. On examination, the patient may come with you with a shock, toxicity, and confusion. There may be tachypnea, tachycardia may be there, hypotension may be there, temperature is raised. There may be mild icterus or jaundice, cholangitis, signs of cholangitis may be there. Bleeding into facial planes can produce bluish discoloration of the flanks like Grey Turner sign, umbilicus like Cullen sign, and groin like Fox's sign. You can see all these three here in the pictures. Then there may be subcutaneous fat necrosis, abdominal distension due to ileus, a mass can develop in the epigastrium. There may be muscle guarding in the upper abdomen. Pleural effusion is present in 10 to 15% of the patient. Pulmonary edema and pneumonitis may be there. Patient becomes confused, and there may be hypoxia. How we are going to investigate the pancreatitis? Then our objectives of investigations are to is the diagnosis of acute pancreatitis is correct? How severe is the attack, and what is the etiology? So these are the three main aims while we are investigating the pancreatitis. We should go for the lab. We see the serum amylase level, but if the serum lipase is available, it is more sensitive and specific. Then, as far the radiology is concerned, we can go for the ultrasonography. But the CT scan, contrast CT scan is the single best investigation to diagnose the pancreatitis. The other thing is assessment of the severity. On account of the differences in the outcome between patients with mild and severe disease, there is a scoring system. We have different scoring system. That is, for example, Ranson criteria, Glasgow criteria, the Apache 2 scoring system, and like this. First of all, we discuss the Ranson criteria. Ranson criteria is different for the gallstone pancreatitis and non-gallstone pancreatitis. For the non-gallstone pancreatitis, at the admission, the age in the years is around about 55 years. This is score 1. Similarly, white blood cell count more than 16,000, the blood glucose level more than 200 milligram per deciliter, serum AST 250 and LDH 350 international unit per liter. Within 48 hours, serum calcium less than 8 milligram per deciliter, hematocrit fall more than 10%, oxygen partial pressure less than 60 mm, blood urea nitrogen less than 5 or more milligram per deciliter, base deficit less than 4 milli equivalent per liter, base excess more than 4 milli equivalent, sequestration of the fluid is more than 6 liter. This is the Ranson criteria with non-gallstone pancreatitis like this. But for gallstone pancreatitis, the age is different. Here it is 70 years. There it was 55 years. WC count is 18,000. Here in the non-gallstone it was 16,000. Similarly, blood sugar here is 220. There was 200, and AST LD level also 215, 400. Within 48 hours, the serum calcium is same, hematocrit fall is same, oxygen saturation same, blood urea nitrogen 2 are more milligram per deciliter, while base efficient more than 5 milliequivalent, and fluid sequestration are more than 4 liter. How we interpret? If the score is 3, severe pancreatitis is likely. If the score is less than 3, severe pancreatitis is unlikely. Or we can say that if the score is 0 to 2, 2% mortality. If score is 3 to 4, 15% mortality, while the score of 5 and 6 leads to 40% mortality, and the score of 7 to 8 is with 100% mortality. Now, there is another criteria that is called Glasgow Scale. That is the modified Glasgow score for pancreatitis, which is like the A, PA, PO2, WCC, CA, calcium, ALT, LDH, glucose, urea, albumin. This is the same the 55-year rate, KPA like 15 into 9 per liter WCB count, calcium less than 2 millimole, and all others like that. The complication of acute pancreatitis are divided into local and systemic. As far as the local are concerned, the pancreas may become there may be pancreatic phlegmon, pancreatic abscess may be there. You can see this in the picture. Pancreatic pseudocyst may be there, and pancreatic ascites may be there. While the involvement of the adjacent organ, it can lead to the hemorrhage, thrombus, bowel infarction, obstructive jaundice, fistula formation, and mechanical obstruction. You can see in these pictures. So, as for the systemic complications are concerned, for example, pulmonary, they lead to pneumonia, anaphylaxis, ARDS, pleural effusion, and for the cardiovascular, it can lead to hypotension, hypovolemia, sudden death, non-specific STTV changes, and pericardial. Then hematological may be hemoconcentration, DIC, GI degrading like peptic ulcer, erosive gastritis, portal vein thrombosis, renal oliguria, azotemia, renal artery or vein thrombosis. Sudden blindness may be there. Central nervous system may be affected like psychosis, fat emboli may be there, alcoholic withdrawal syndrome may be there. As far as metabolic are concerned, there may be hyperglycemia, hypocalcemia, hypertriglyceridemia, and encephalopathy. Fat necrosis may be there, which can cause intra-abdominal saponification and subcutaneous tissue necrosis. Now, how we are going to manage the pancreatitis? The mild pancreatitis, with no systemic complication, low Anson's criteria, and sustained clinical improvement, and the CT scan rules out the necrotizing pancreatitis. We label it as a mild pancreatitis, while the severe pancreatitis is like onset of encephalopathy, hematocrit more than 50%, urine output less than 50 ml per hour, hypotension, fever, or peritonitis may be there. Elderly patient with 3 or more Ranson criteria. Then how we are going to manage it? Admission to IDC, HDU, high dependency unit, or intensive care unit, mild to moderate pancreatitis. Then resting the pancreas is the main uh, thing we are going to, how we are going to manage the pancreatitis through restriction of oral flow and foods with a nasogastric suction, and we can add with the H2 receptor blocker, and patient should be started on the TPN, total parenteral nutrition. Analgesia, strong analgesia should be given to the patient with aggressive fluid rehydration and oxygenation with invasive monitoring of the vital signs, central nervous pressure, urine output, and blood gases, and frequent monitoring of hematological and biochemical parameters. Then in mild to moderate pancreatitis, we give the antibiotic, broad spectrum, ERCP within 72 hours for severe calcium pancreatitis or sign of cholangitis, and we can go for the CT scan to see if there is organ failure. Supported therapy for the organ we have to give for. Then in gallstone pancreatitis, early interval cholecystectomy with intraproteocular angiogram in 3 to 5 days when pancreatitis resolves. If there is a pancreatic necrosis, we have to do the surgical debridement of the patient, severely ill and refractory to medical treatment. If there is a pancreatic abscess, antibiotic and percutaneous draining placement are operative debridement and placement.